And then you just click on the PowerPoint and
As originally,
Cool. Awesome. Thanks, bro. Okay, good morning, good morning. None of you know me, so let's get started. I have not formally taught a class ever, so we're going to get through this together. If you have any questions, just shout them out. Online people, you can shout out or chat, and if you guys catch that, will you let me know? There's only like 95 slides today. I can't imagine us filling all 3 hours, but we'll see how this goes. So we're going over gastro today. Also, I have no problem referring through you guys' book. I haven't read your book, so I don't know exactly what yours says, and I'd rather you know what the test is applying. So let's refer to that if anything comes up as a discrepancy. Do some anatomy. We're going to do some things with shock, general management of the abdomen. The abdomen is interesting because unlike other body systems that we deal with, you're not necessarily going to be able to dial in exactly, but you should have some pretty decent treatments. The more you know your pathophysiology and your anatomy, the better you're going to be able to narrow down to what you think's going on. But at the end of the day, even the doctors are going to want imaging thing before they actually make decisions on these. So we're going to go over acute and chronic gastrointestinal hemorrhage, peritonitis, the genitourinary system. We'll get into some dialysis and things, and basically just all things abdomen. So basically what I just said, actually, you do not need to determine the exact cause. You guys need to be able to recognize life-threatening situations. A lot of us, as I'm reading through the slides, always says call for ALS, call for ALS. So I'm sure you guys have that down by now. Who wants to tell me what a solid organ is? Okay. What else? Okay. What's the difference between a solid and a hollow organ? Good. So your solid organs, your liver, your spleen, your pancreas, your kidneys, they're exactly what they say they are. They're solid. Your hollow organs are going to be your intestines, your stomach, etc. Your urinary tract is considered hollow, other than the kidneys. So important to remember your solid organs, especially in trauma, bleed a lot. They're very, very vascular. So try and watch out for those when you're doing your trauma assessments and try to think of what's in that area. If it's a solid organ, you can pinpoint it a lot easier than if it's a hollow organ issue. Hollow organs tend to be more generalized or they'll move. But if they're having right upper quadrant pain, you can lean a lot closer to liver, gallbladder, things like that. These screens are not showing up all the way. Okay. So here on the left are all of your solid organs. The right is all of your hollow organs. I'm sure you guys have seen this in your book. Anybody have any questions over it, want to spend any time on it? We're going to get into each one of these organs more specifically as we go. So, entire digestion process takes 8 to 72 hours. Obviously, you're going to start esophagus, move your way down to stomach, get into your whole intestinal tract. Some things will move through really fast, and some things get absorbed quicker. Some things will literally be in there for 72 hours. So as you're going through people's vomit or their stool, if they're recognizing certain things in it or you recognize certain things in it, it can be up to 3 days before. Especially when you get into just the generalized abdominal pain, hollow organ stuff. We always go to the last meal, but in reality, they could have this from 3 days ago. Unless it's like an infection type thing, then it's probably more localized. Do you guys know about the portal veins? You know much about those? Okay, we're going to get into those in a little bit too, but just good to know. Stomach secretes hydrochloric acid to break down your food. This is your saliva is actually your first form of digestion, your saliva and chewing. It gets down to your stomach, you've got hydrochloric acid. Food will sit in there for a while. Your patients that end up having a lot of nausea and vomiting, they'll see food in there from a day before sometimes, depending on how sick they are. The stomach can stretch many times its size, and it will absorb some materials, but most absorption is not going to start until the duodenum. So once we get into the duodenum, this is your first part of your small intestine. The pancreas, liver, and gallbladder connect to this part of the system. Those three solid organs are tied together very closely. If you have problems with your pancreas, you can tend to have problems with your gallbladder. If you have problems with your gallbladder, you can tend to have problems with your pancreas. So keep those in mind as kind of referred organs. Then obviously the liver affects everything. If your liver is damaged, we'll get into this once again more later, but if you have a lot of hepatitis or liver inflammation, acute liver failure, it's going to back up into all the portal veins, and it's going to start putting toxins and things into the rest of your body. So the liver is a very big organ as far as your general mentation and function. Amylase breaks down starches into sugars. I'm not sure if that's on your test or not, but that's just an enzyme. So the liver assists in digestion by secreting bile. It goes down the bile ducts. Gallbladder does as well. The gallbladder breaks down fatty acids or fatty foods. If you, I'm getting ahead of myself. We'll get into that in a bit. Liver also creates glucose stores. So a lot of the glucose that's coming out of the intestinal tract will get taken up into the liver, gets converted into glycogen, and then it will get stored throughout your body from there. What medicine do we use to release glycogen? Do you guys know? I don't even know if you guys can give it, but probably not. Glucagon. So glucagon we carry in all the ambulances. Glucagon will release those glycogen stores. So it's a slower process. It's not as quick as D50. It's going to take 10 to 20 minutes plus. And it's only effective if they have glycogen stores left. So just sidetrack for you. The small intestine turns chyme into substances that can be absorbed. So your intestinal tract has nutritional pathways and blood pathways. All the food's got to get broken down into small enough particles to be taken up into those tracts. And then it's got sections of the jejunum and ileum. The large intestine, the chyme is now turned into feces. The primary role of your large intestine is to reabsorb water. And this is your site of bacterial digestion. Most of your digestive tract is actually bacterial. So this is where probiotics come in. It's not necessarily something you need to know, but as a side note, everything I've read says there's more bacterial cells in our body than human cells. So it's important. Your patients that end up with C. diff and that have really poor digestion tend to have a pretty poor bacterial complement. A lot. I don't have an answer for you. Yeah, it's tons. And then there's different strands, and the more strands you have, the better the flora. Sure. I'm sure somebody did. Going back here, the large intestine, if you have people that have colostomy bags, more often than not, they've only removed the large intestine. They still have a lot of their small intestine tract, but it's going to depend on their pathophys of what disease process they have. All right, the spleen is located in the abdomen, but has no digestive system function. This is part of your lymphatic system. It also is a big reservoir for blood and antibodies, excuse me. So this is another one of those organs. If you've got somebody who crashes on their bicycle and they take a handlebar to the gut, or they're in a car accident, anything left upper quadrant, you're going to want to really be suspicious of the spleen. People that tend to have these injuries, whether it's spleen or liver, hold on for a little bit, and then all of a sudden they just dump. So watch their compensatory mechanisms, see if they're in compensatory shock. But there's been several catches that I've seen of these that as they rolled into the ER, they just absolutely shot down. So keep those in mind. They bleed a lot, a lot, a lot. This is the genital system. The abdomen also holds your reproductive systems for both female and male. We're not going to get too deep into each specific part, but you guys can look through that in your picture. I imagine it touches on it later in your book in another chapter. There is a couple things that will come into later, but not too much. No, especially, we'll get into the specifics later, but just have a general idea where those things are, and then we can refer to the process a little bit more later. Here's your urinary system. So kidneys are your other solid organ. They are filtering out toxins. So liver filters toxins, and the liver stores glycogen, and the liver does a whole bunch of magic things. But the kidneys are your last filter before everything heads out your ureters. They are also responsible for your electrolyte balance. So patients that, why do we do dialysis? Okay. So we're filtering out all those toxins because they don't have the ability to anymore. You only need a very small portion of kidney to actually do that, but we are taxing our kidneys constantly throughout our life. That's why it's okay to donate a kidney to somebody, and most people do okay. But we also see patients all the time that had 2 kidneys that are on dialysis. So you can be on acute dialysis where it's just a short-term basis because you have some kind of disease process or illness. And then there's obviously the long-term dialysis, which we deal with all the time. Kidneys are going to be responsible for getting rid of all of those toxins. So if you have patients that are not mentating properly, but they have kidney history, there's a decent chance that they're getting toxic within their system. You can start considering things like hyperkalemia, ammonia, lactates. All these blood labs are going to elevate. And it's not that the kidney is necessarily producing those, but it's not being able to filter them out. The kidney is primarily responsible for filtering out urea. Urea is a form of ammonia. So you will hear seeing it sometime if you pay attention. The care providers there will say this patient chronically gets an elevated ammonia, and then they become altered, and they usually have a kidney history. Same thing with hyper K patients. They're not filtering everything properly, and they're not restoring their electrolyte balance. Same thing with calcium, magnesium. So that gets a little bit deep, but understand the filtration process for these. They're also going to be responsible for your blood sugar levels a little bit because they're going to filter that out, and they're going to maintain your osmotic pressure with your fluid balance. So if your kidneys are hurt, you're just like your liver, you're going to back up the rest of your system. Patients with your Foley caths, try and pay attention to their urine output and their urine color. See what they're discharging. You can get a lot of indication of what's going on in their body system based off of that. And then here's the rest of your pathway. So you go kidneys, ureter, then bladder. Your Foley cath gets inserted up here, and there's a balloon that sits just on the other side of the bladder. And it stays in there. That's what holds it in place. Also a problem when you have an altered patient that tries to rip them out. So this is basically what we just talked about. They will metabolize some drugs as well. Your kidneys filter 200 liters of blood a day. They will produce some hormones, and they play a major role in homeostasis. I don't think you guys need to get into what hormones, but just know that they do produce hormones. Your brain ultimately exerts your control and urge to void. Thus, a lot of times when our patients become unconscious, they'll become incontinent. How are we doing? We're flying through this. Do you guys want to take a break? No? Online world's okay? Sweet. They said there's only 95 slides today, so just keep going. All right, acute abdomen. These are going to be your sudden onset abdominal pains, and it's not talking about my stomach kind of hurts. These are strictly referencing your severe abdominal pains. This is appendicitis, acute liver failure, things of that nature. It's very, very painful. It's very sudden, and they can often be deadly. So these are the patients that we're trying to catch. These are the ones we don't want to let slip when we when we get on scene. They're like, oh, we have abdominal pain, just let them go POV. These are the ones you want to pay attention to. Peritonitis. So you have your perineum. Perineum is the mucosal layer around your abdomen and all of your organs. Peritonitis is inflammation of that, of the peritoneum. So this is going to be an infection. It's going to be if they get a hole somewhere in their intestinal tract, if they perforate anywhere. Appendicitis is a really popular one. So because of one, the potential for blood loss, and two, the potential for the broken down food to get into your abdomen, these patients get really, really sick really, really fast. We just had a call, Max and I, last week. Gal unintentionally overdosed on ibuprofen, and she perforated her stomach. And so she had to go up for immediate surgery. Same thing, whether it's disease process or the toxin, she ended up having a perforation in her stomach that was leaking bowel contents into the rest of her abdominal cavity. If it becomes traumatic in nature, obviously your abdominal cavity can hold a lot of blood, so you're going to have a lot of potential for shock really, really fast. They tend to almost always have a fever, and they're going to be your very typical sepsis presentation with the addition of abdominal pain. All right, so you have these two layers of your peritoneum, the visceral and the partial. The partial lines the abdominal cavity, and the visceral covers the organs. Visceral pain is referred to as a pain of the hollow organs. As we kind of talked earlier, it's usually not, it's not as localized. Visceral pain is a little bit more vague, tends to be more generalized. You'll see a lot of these patients too, unless it's even sometimes in a perforation, but not as often, their pain will move because you're dealing with the intestinal tract. So as it moves and has its peristalsis and flexes and stretches, and then food in the gut moves around, their pain can move as well. You also don't have as direct nerve innervation to these areas. So the pain's transmission's being sent to that nerve, and then your brain's just trying to determine where it is, but it's not as localized as if you touched your finger where you have a ton of nervous sensors. There are organs in your body that have referred pain. So this one is referring to cholecystitis, which is your gallbladder. Anything right upper quadrant, keep in mind liver and gallbladder. You can also include your pancreas. In the gallbladder, you will tend to have referred pain to your right shoulder. There's a few other signs like that in the abdomen, but this is kind of the only one that it references. At least in the slides, I don't know about in your guys' book. So this will usually show up 30 minutes after a fatty meal. It can be a little longer, but as soon as 30 minutes. So I think it's more common in men actually, but I'm not positive. We can look in your book and see. Once again, this can affect your pancreas as well. So you can end up with a pancreatitis due to a gallbladder issue. This can be gallstones are really common. Sometimes they'll just remove the stones. Sometimes they'll remove the gallbladder. You don't technically need it, but it does help in the breakdown of fatty foods. The reason this is a good one to ask about what they've eaten, because if they've had a really fatty meal recently and they're having shoulder pain, it's almost a slam dunk. This is one of the ones you can kind of call. Also, they can get very, very sick really quick with these. So, so all abdomen will make you vomit. Sadly, they all get belly pain, they all get nauseous, they all vomit. But they're going to have a lot of severe pain in the right upper quadrant. And then because the gallbladder affects the liver, affects the pancreas, it starts backing up those systems. And then that backs up the rest of your body. Peritonitis will also cause ileus, so where it'll just kind of stop moving stuff along in the gut. Associated with loss of body fluids in the abdominal cavity. This, we talked about this already, this can lead to hypovolemic shock really fast. Who knows how much blood is in the body? So in American terms, it's a little over a gallon. So it's really easy to fit a gallon of blood into your abdomen, especially because it stretches. It's also really easy to miss the fact that they're bleeding. So just keep that in mind. Much like femur or pelvis, you can bleed out into your abdomen and nothing flat. Patients with diverticulitis and cholecystitis may have elevations in their temperature. I can tell you that most other abdominal areas can also elevate the temperature, so it's not necessarily a slam dunk just because they have an elevated temperature that it's one of those. This is a quick chart. Very, very basic symptoms. So we'll run through it real quick since we have some time. Appendicitis is going to be around the navel to the right lower quadrant, and its common sign is rebound tenderness. Have you guys ever heard of McBurney's point? Okay, so take a second, find your belly button, and find your iliac crest, which is the top of your hip. Go in between those 2 points. Now, the appendix can be in other places in your abdomen, but more often than not, that is the statistical area that it is. So if you find that point on your patient and they're having right lower quadrant pain, you push in on it. The rebound tenderness is when they have more pain when you let go. So that area is called McBurney's point. It is a specific thing to appendicitis. Yes, be a good bar. These patients get really sick really fast too. Get septic really fast if their appendix does burst. So this is a good one for us to look at because it's a very simple external test, and if it can raise our index of suspicion for that, we can pass that along to the docs and hopefully get that judgment going a little quicker. I'm sure there's more to appendicitis than I know, but a lot of people just kind of develop appendicitis one day. They were feeling fine, and then all of a sudden their stomach starts hurting. Progressively gets worse over several hours, and then if they wait too long, it will burst, and ultimately it can be fatal because you get septic, but more often than not, they'll get surgically opened, cleaned out, and the appendix will be removed, and they're out of the hospital in a couple days. I don't know. I've never heard of it, but I'm not going to say it hasn't happened. I would think, just because they think the appendix used to be used more for nuts and berries and things, and we don't eat as much of that anymore. So they're not really positive exactly what it does, but they are pretty confident we don't need it. So they have a pretty low threshold for taking it out. Cholecystitis, we just talked about. It's the right shoulder pain and right upper quadrant. Who wants to tell me about ulcers? Any thoughts? Kind of. Yep. So an ulcer is a breakdown of the tissue lining, especially the mucosal layer of your intestinal tract. There's obviously we're talking about gastro, so there's pressure ulcers and things too. It's the same thing, just on the inside of your body. So they can make you... Mm-hmm. Yeah, they tend to not be fatal early. They tend to be a more longer disease process, but they can, definitely. Many of the GI tract issues will develop ulcers, and we'll get into that in a little bit. But they're picture raw tissue that not only is being squeezed back and forth, but can probably bleed, can perforate, and then you're running food and everything else across it. So it ends up being really painful for them, can make them very sick. It's basically an open sore to this entire bacterial world. So keep in mind your GI tract, as much as we want to believe it's on our inside, is actually, for all intents and purposes, an external surface of our body. It's because mouth to anus is open to the outside world. The only way it gets into the body is to go through the different pathways. So for all intents and purposes, picture your GI tract as an external tract that's exposed to the world, and then anything that you come in contact with easily gets into your GI tract. Taking a break? We doing good? Okay. I'm sure we all know about AAAs. Who wants to tell me about them? Okay. Okay, so yeah. Okay. So the aortic arch and the aorta in general are big vessels, right? Carries the bulk of our blood. And you're absolutely right. So as it bulges and then eventually ruptures, there are layers to the aorta. So you can have what's called a dissection. They can get, talk to the docs if you bring one in that you think it is. Eventually you'll find one where they'll actually have a balloon in the x-ray picture and it's got a pooling of blood inside there. And it freaks us out because they're like, that's going to pop. And they will go in, they'll surgically repair them if they get bad enough. And it can be very fatal because they can bleed out so quick. Yeah.
With the dissection especially, more than the actual aneurysm, can you absolutely see those opposing bilateral blood pressures?
You can, yeah, because it's got the different systems.
Yeah.
Yeah, and then one of the only areas in your abdomen that you can feel like tearing sensation is your aorta. So if somebody tells you, I feel like I'm just getting torn open, you take it more seriously. Same thing if you palpate and you feel a pulsating mass. Occasionally, if somebody's heart has a lot of rebound strength at that time, you'll feel like you're feeling that, and it's just their chest kind of bouncing. But you'll actually feel a pulsating mass if it's a AAA. I've only had one that I've seen, but it was obvious. She didn't dissect as much as you can, so she actually maintained a little bit through the hospital, but she did eventually expire. And that was her wishes. She had a DNR and things. So, cystitis is inflammation of the bladder. It is common too if you get a lot of pain in your lower abdomen, bladder area. Sometimes, especially in the older population, their bladder will get so full that it'll actually seal off their exit pathway. So they'll have to go in and they get a Foley cath and then it'll flow out and they'll be fine. They've got a little, it's kind of like an ultrasound that they'll put over that and they'll measure it. But that's an actually common problem for the older population. So same thing with Foley casts, they're going straight into the bladder. That's why they have a high index of UTIs. And we'll get into that in a bit, but I'm fairly confident everybody in here is pretty well versed in UTIs. Kidney infections, where are you going to have kidney pain? Flags. Yep. If you have one side over the other, it can certainly be a single kidney that's injured, but start thinking kidney stones. If it's both kidneys, start thinking acute kidney injuries, the system shutting down. There's not a whole lot else back here if they weren't involved in trauma that's going to give you flank pain. It's not to say something couldn't be referred or be different, but generally speaking, it's kidney. As the kidneys get taxed, they can get sore like that, and they'll get some pain in there. So if they're backing up toxins from either the rest of the body that's filtering to the kidney, or if the kidney is starting to become injured or failing, whether that's acute or chronic, they can get some pain there. Pelvic inflammation. So this is pelvic inflammatory disease. This is only for women, most commonly due to multiple sexual partners or some kind of STD. Not necessarily one of the, like a big STD, but just a sexually transmitted infection. They'll get a lot of pain in their lower abdomen, and it was always referred to me as the pelvic shuffle. So if somebody shows out and they're kind of shuffling from their house in their robe and it's a woman, keep it in mind that it could be pelvic inflammatory disease. It tends to be lower into the pelvis region. Pancreatitis is going to be both upper quadrants, hang more to the left, but definitely can give you right-sided pain. Once again, relates to your gallbladder. These guys can have blood sugar issues. They're going to have gallbladder issues because the inflammation, whether it's the gallbladder that inflames the pancreas or the pancreas that inflames the gallbladder, they get in each other's way. They'll usually be febrile. They'll usually be pretty nauseous and feel pretty crummy. Pneumonia is an interesting one that we don't give enough credit to. Pneumonia will cause you pain into the upper abdomen, especially the epigastric area. And it's just because they're so close in nature and because the infection's right there. But we don't put enough weight into, if you're having quote unquote abdominal pain, we tend to write off the heart and lungs sometimes. And we're probably jumping to the gun on that a little bit. If you're having upper abdominal pain, we should be assessing your heart and your lungs as well. Some chest pains too will present epigastric, so just don't write them off. Everybody gets 12 lead. Your medics are going to love you and me now. Hernias, that we're all pretty well versed in. So breaking through the peritoneal wall. These can be emergent or non-emergent, and it just depends. It becomes more emergent if they get a strangulation injury, which we'll talk about later. A lot of people walk around with hernias for weeks or months. They finish the baseball season or whatever, and just life goes on. As long as stuff keeps flowing, it just kind of sits there and doesn't do them a lot of harm. Oops, sorry. And then we talked about peritonitis already. Who knows what a hernia that goes into your chest cavity is called? Hiatal. Yep, it's a hiatal hernia. More people have these than they realize, but this can cause you some other chest-related ailments, and they tend to have some strangulation injuries as well. So any condition that allows foreign materials into the abdominal cavity can cause peritonitis. So remember I said your GI tract is the outside world. So anything gets through that into your abdomen has the potential to cause you peritonitis. Remember, itis means inflammation, so inflammation of the peritoneum. Nearly every kind of abdominal problem can cause an acute abdomen problem. This is another problem why the abdomen's difficult. It's also a problem you guys will see, and Max and I had this again a few weeks ago. You'll see GI patients that you've ran on for the past 3 or 4 months and they're not getting answers, and they don't know why. Part of it is that they're not sick enough yet, and I don't mean that in a negative way. The disease isn't rearing its head enough to be caught, unless somebody just had a really good suspicion and followed it down a track. Usually they're going to start with simple diagnoses and work up to the more extravagant ones. So they'll start having a small amount of pain, and over the next few months they develop a much worse process. So if you show up at somebody, I've been having stomach pain for 3 months, our common thing is to be like, okay, whatever, get in the ambulance, let's go. But in reality, they can be getting worse. So take in their clinical presentation and see if they're getting sicker. Bleeding within the GI tract is a symptom of another disease. It can be upper or lower. So if you think of it just in length in general, if they are pooping out dark red blood, how far away is the bleed? It's pretty far. Same thing if they're vomiting dark red blood, it's probably not in the upper, it's probably more lower. It can only go up so high. Stuff moves down, but just keep it in mind. If they're pooping bright red blood, it's usually pretty close to the exit. Keep in mind, they're going to tell you that they pooped out a lot of blood, and it's because it's mixing with the water in their toilet. So we've all had a nosebleed or whatever into the sink. It's going to look a lot worse, but try and gauge if they're bleeding a lot or a little, and you guys are pretty good at that. You see people bleeding all the time. Esophagitis is an inflammation of the esophagus. The effects are irritation and swelling. We kind of write off the esophagus a little bit as being a culprit for the problem, but especially in the chronic sick patient that deals with a lot of vomiting, or they're an alcohol abuser, or they have a lot of acid reflux, they can actually end up with a lot of issues in their esophagus tract. You can also have, it's not exactly esophagitis, but you can have foreign food obstructions commonly in the esophagus. There is a gal at Pacifica on Dalton that always has an obstruction in her airway tract, or not her airway tract, in her esophagus. Usually meat, and usually it's not a big deal. Some ERs, their first line of treatment is to give you a Coke and see if you can get it to go down, or a Pepsi or whatever. Some will deal with it differently, but it's usually not a big deal. It's almost always meat, whether it's steak or whatever. For this gal at Pacifica, it's always pot roast, always. And they continue to feed it to her. So they will usually be, they can't swallow very well, so getting a backup of saliva. So they'll start spitting up saliva everywhere. They usually feel like they want to vomit. They'll have some pressure in their chest, just like something stuck. And that's because it is. So just keep that in mind. Gastric esophageal reflux disease, also known as heartburn. Usually the sphincter between the esophagus and stomach is allowing acid back up. I'm sure we've all experienced some degree of heartburn at one point or another. Some people live with this every single day, and some of them are taking meds with it. They do have some surgeries they can perform to deal with this a little bit, but that constant acid into their esophagus will start to eat away at it over time. These patients become candidates for, excuse me, for Mallory or Weiss tears and those sorts of things, which we'll go over in a little bit. Bleeding can definitely occur if the damage is long term. Once again, they're going to start bleeding into their probably their abdominal tract, potentially their this area. It's not necessarily going to be into like their lungs, but this is peptic ulcer disease. We touched on this a little bit. So peptic ulcers erode the layers of the GI tract. The acid eats away at it. There are other disease processes that cause ulcers, just as part of the disease, because you're mainly in like autoimmune things where the body's eating at it. Usually a result of I don't even know how to pronounce that, pylori infection. And then chronic use of non-steroidal anti-inflammatories will cause this. So chronic use of Tylenol shuts down your liver, potentially your kidneys. Ibuprofen tears holes in your GI tract and can still tax your liver and kidneys. Some of these, if you have an acute liver injury from, say, Tylenol overdose, the patient can go into the hospital, get cleared up, and be symptom-free for years, but the damage has already been done to their liver, and they can end up in acute liver failure 5-10 years later. It's actually really sad because some of them did this in a different state of their life when they were depressed, and now they're happy and they want to live, and now they have acute liver failure and they may or may not be a candidate for transplant. Alcohol and smoking can affect the severity. Alcohol is really hard on the GI tract of anybody who's got GI problems. General rule is that they probably shouldn't drink, and if they do drink, they shouldn't drink much. Peptic ulcers affect men and women equally, men more frequently in the elderly. It's a burning, gnawing, sharp pain, upper abdomen and below the sternum. Here's your symptoms: nausea, vomiting, belching. They'll get some gas buildup, so that's where the belching comes from. If the ulcer is lower in the system, they can just be gaseous in general. Some of these will heal without intervention. Some will need to be put on antibiotics, and some will need different routes of therapy to make sure that area of tissue is not being harmed anymore.
It says it's anal subsidized after peeing. Why would that be?
I would assume because the acid's being absorbed by the food, but I don't know. Maybe because it's just routing more blood and things to that area of your body. I don't know. I don't have a good answer for you. I'm sorry. How we doing, online world? Everyone good? All right. This is a Mallory Weiss tear. So this is between your esophagus and your stomach junction. These tears can lead to a lot of bleeding, and because it's a vascular area, it's another one that can, once again, be easy to miss. It's going to cause them a lot of pain, but they can still bleed out really quick. Alcoholism is naturally a problem. Eating disorders tend to be an issue. GERD can kind of eat away at that area. They can be very minor to very severe. Ultimately, they're going to need some imaging and potentially a trauma surgeon. So these sorts of things, when you're treating them, keep in mind, just like when we treat a trauma patient that was in a car wreck, they don't need us, they need a surgeon. And if you suspect that these are the problems, they still need a surgeon. So we can only do so much for them on scene. It's actually pretty minimal in the extent of the disease. Borhave Syndrome is almost the exact same thing as a Mallory or Weiss tear, but instead of being right at the junction, it's a longitudinal tear down the esophagus. Can present after a large meal or after alcohol consumption. Good. Esophageal varices, these are the common ones that we contribute to alcohol. All three of those rank into that same category. They're all very similar and basically related. Esophageal varices deals more with the veins and specifically the amount of liver disease. You can still end up with ruptures of your varices, and these are usually sudden and they're usually very dangerous. So if you've got, especially if families there try and probe about alcohol consumption, and family usually is willing to sell them under the bus, keep it as a potential. Most of these patients, if it's bad enough, they're going to have your classic shock presentation, and then we're just going to get into the ER anyway. But once again, the more you dial this in, the better. The more you can paint that picture for the doc, the more he's probably going to take some of these patients seriously and get in there quicker. Hemorrhoids are more common than we want to believe. Nobody wants to talk about them. Nobody wants to admit they had them, and a big bulk of the population has. Often confused with a prolapsed bowel. These are usually just a small, it'll almost look like a small piece of tissue hanging out of their butt. They can bleed. It's usually bright red because it's right there at the opening. It's usually itchy for them, and they have a hard time keeping them clean. They can tear them, which is where your bleeding usually comes from. They're usually easy to treat if the patient wants to admit that they have one. Sometimes they'll go away on their own. Sometimes they can go in and they can band it or cut it off. It's, for more or less, it's a very minor issue, but because something's coming out of your butt, everyone panics, and nobody also wants to admit it. So it's kind of a weird situation for us. Some patients will come right out and tell you, and some will just be like, I just want to go to the hospital. Just get me to the hospital. More often than not, this is not an emergent issue. They'll feel like it's emergent because they're bleeding out of their butt. Tends to not be a lot of blood. Obviously assess it and make your determination. If they have a prolapsed bowel, also it's usually not massively emergent unless for some reason your patient's condition dictates it. But these patients tend to be pretty stable. If they've had one hemorrhoid, they will usually end up with another one at some point. Common from straining too much. So as our diet gets to more and more processed foods with less and less fiber and more consolidated things, we're ending up with more hemorrhoids, more diverticulitis, more bowel disease.
A lot of it just like a 5x9 with some sterile water.
Yeah, sometimes you don't even do that. Kind of position them in comfort and keep it clean and take them down. There's, once again, there's not a lot we're going to do for them. Don't push it back in. Gallbladder stores digestive juices and waste from the liver. Gallbladder is going to move bilirubin down into your digestive tract. Bilirubin is what makes your poop brown. So if your patient has gray stool, it may be a gallbladder issue. Once again, these usually become sometimes people know they've had gallstones, but more if we're going to see them, it's often that they're having severe abdominal pain that started suddenly, and they'll likely end up in surgery. Sometimes the blockage does pass, just like a kidney stone. The only difference is they usually won't remove your kidneys, and they have a pretty low threshold for removing your gallbladder. Severe cases, your gallbladder can rupture. If it does rupture, just like all your other organs, it's a sepsis problem. So I'm sure you guys are seeing the trend here now. Anything in your stomach is a candidate for sepsis. Here's your general symptoms. People that have their gallbladder removed tend to be more gaseous. They don't break down fats well, but their symptoms relatively resolve once it's removed, and they tend to not have that issue. It's a good question to ask if you're suspecting it, because so many people have had it removed now. You can check that off your list if they already have. And it's often a laparoscopic surgery, so you may not see any scarring. Pancreatitis, once again, goes hand in hand with gallbladder. Keep that in mind. Inflammation of the pancreas. So again, itis means inflammation. So pancreas is inflammation, or pancreatitis is inflammation of the pancreas. Your pancreas is your source of insulin. So if your pancreas gets sick, your blood sugars are going to be a little out of balance. And it does form some of your digestive juices as well. They're going to have a lot of severe pain. Many of these patients have had pancreatitis before, and they'll tell you. And if they tell you they've had pancreatitis and it's in that quadrant, you may as well just believe them because they're probably right. They'll have some abdominal distension. They're going to have a lot of tenderness. They'll be tachycardic, and they'll have a fever. Sepsis or hemorrhage may occur, again. Appendix, it's a small recess in the large intestines. Once again, low threshold for removing it. Can be very lethal if it does burst and left in. But this is a routine in and out. You might spend a day or two in the hospital, but they're pretty much going to go in, cut it out, and send you home. Okay. Gastroenteritis is just an inflammation of your gastrointestinal tract. This has to do with infections typically. It can be bacterial or viral. Often this is your foodborne illness or your Giardia, something of that nature. So common GI symptoms, Pepto-Bismol dance, pretty much got you covered there. If diarrhea continues, make sure you're checking their blood sugars and they're assessed for dehydration. Same thing with vomiting. Same thing with your alcohol abuse patients. They tend to become malnutritioned and they become dehydrated. And as a side note, we're not getting too deep into this, but if you have a patient that strongly abuses alcohol and they're giving them D50 for a blood sugar issue, consider that it can cause psychosis too. So the ER will probably give them thiamine, which pretty much prevents that, but they're so malnutritioned it can cause psychosis. So you still need to give it to them. You can't leave them low, but just have that suspicion if they are an alcohol abuser that you might mention at the ER. Oftentimes the ER is not going to see these patients at home, and they'll get some indication off of their blood labs, but we have that firsthand perspective, and so we do a big favor by bringing that scene to the hospital. Diverticulitis first started being recognized around the turn of the 19th century, or I guess the 20th century, in the 1900s. People used to eat a lot of fiber. We are consuming more and more protein, more and more processed foods. People are getting bigger and stronger, but along with that, it affects our GI tract. So this tends to be low colon issue. They'll have a lot of pressure in their colon. That pain can radiate into other areas. Occasionally, the pain will radiate so low that they'll actually feel like they have some genital pressure. Can also go up or out. They don't do well with popcorn, seeds, things that kind of get stuck in the end of the colon. And then it's really painful for them. Fecal matter gets caught in there, bacteria gets to take hold and can form. These guys are going to have body chills, aches, fever, malaise, nausea, bleeding. Because it's so close to the end of the GI tract, a lot of the bleeding will be bright red. Ulcerative colitis, side note too on all of these GI things, as far as the GI tract, the incidence of these is increasing rapidly. We're seeing more and more patients with them, not only in our field, but in medicine in general. And we're starting to have a lot of sick GI patients. They're also have come a long ways in the treatment of GI. So the medicines are getting way better. They're not doing as many abdominal resections as they used to, but it's still a commonplace thing. So if you see a patient that had an abdominal resection, they're usually going to be cut almost across their entire belly. They're going to have wound vacs. They're going to be in a lot of pain. The downside and why they're getting away from it if they can is a lot of these diseases will jump from one area of the bowel to the next if you cut it out. So if they can leave it in, they want to. But if you're so sick or you have a bowel obstruction, then they'll take it out. A lot of the ulcerative colitis patients are ending up with colostomy bags. It's an autoimmune disease, and we are seeing an increase in autoimmune diseases as well. So in ulcerative colitis, it's exactly what the name says. It's a lot of ulcers. They'll get a lot of inflammation, but their GI tract becomes really raw, and it tends to be localized to the colon. Very painful for them. They usually have bloody stools, very runny stools, a lot of abdominal pain, and these guys can feel totally normal and then later be completely sick. Or it can be a chronic thing. Some of them will know what triggers them, some won't. Some will be on good meds, some will be on bad meds. If they're a new diagnosis, a lot of them will be on prednisone. So if you see the really puffy person, a lot of these diseases are getting put on prednisone. Prednisone causes a lot of weight gain.
And then there's been talk about Diverticulitis, but they said they're going to try to send you.
Okay, how's sound now, guys? Sweet. All right. So like we said earlier, the ulcerative colitis patients, your Crohn's patients, your diverticulitis patients, these are going to be the guys that have been, thank you, they're getting sick over time and they don't really know why. And then eventually they get really sick and they finally get the testing they need. The jump from abdominal pain in the ER, potential CT, to getting like a colonoscopy is a pretty big jump, and it tends to wait until they're pretty sick. So once again, just give these patients the time of day. If they've been saying it's been going on for a long time and not getting better, they might have a good reason. Irritable bowel syndrome is a cousin to colitis. It's more of a vague term. So if they can't quite nail you down with something, you get labeled irritable bowel. It is the fibromyalgia of the GI. So you have generally abdominal pain, can be food related or not food related. You tend to have issues with your stool being runny. Then you can be constipated, and it's just kind of all over the board. It's hypersensitivity. They get a lot of cramping pain, a lot of that visceral pain we talked about earlier. It says there's a psychiatric disorder connection in IBS, and I don't know about that, but I believe them. So, yeah. Crohn's disease is the other cousin. So this can involve the entire GI tract. The three of these tend to be linked with family hereditary, especially Crohn's. There's certain populations that tend to marry within the same population. And it's a form of Jewish people, and I don't remember the term for them, but they tend to get Crohn's disease a lot, and it's really common in their genetic pool. It's also becoming really common in our society in general as we've evolved into the foods and things that we eat today.
It's like diet-based. It's all you said hereditary, but it's like also diet.
It's very hereditary. I can't say it's diet-based. That's a conversation for somebody more than us. But as our foods have changed, as we've modernized society, this has become a more prevalent issue. So you're probably not going to find it anywhere in your books that it says it's food-related, but consider it modernization-related. These will have presence of signs and symptoms outside the GI tract. They'll tend to have, you can get lesions, you get the joint pain. If you get sick enough, you're going to become hypotensive. Especially in Crohn's, but so let's go back for a little bit. Let's go to colitis. This is involving your colon. So because you're going to have runny stools and things, you're going to lose your water reabsorption. You're going to be losing some blood potentially. And so these guys are going to get really dehydrated really easy, along with the potential for sepsis and hypovolemia. Irritable bowels, which is very painful. It's not specific to one or the other. Crohn's disease can be anywhere in the GI tract. It tends to, the areas that get disease start to lose their function. So you're not going to be able to uptake from those areas as easily, at least while the disease is active. The new medicines help and they can reduce some of the disease, but then they get a lot of scar tissue still just like the other two. They lose the ability to absorb water in the colon. They lose the ability to absorb nutrition in the rest of the tract. They can still become hypovolemic. You get so much inflammation throughout your GI tract that you will basically third space fluid into those areas. So they can become really hypotensive over the course of their condition. Sepsis is really high as well, or potentially high. And then all three of these get into, so any organ that you have issues with, you raise your chance of having cancer. So anything in the GI tract, when you talk about Crohn's, colitis, they raise the potential for colon cancer, those sorts of things. The sad part about the three of these is they tend to, because it takes long to diagnose or it takes a while to develop, the disease can be relatively advanced by the time they get the treatment they need, especially with colon cancer. We're not getting into cancers much on this, but colon cancers a lot of times by the time they find it are stage 4. Pancreatic cancer a lot of times by the time they find it is stage 4. So pathophysiology of the urinary system, we went over this a little bit already, so we'll kind of breeze through it. We're going to touch on dialysis in here. Pre-hospital care is usually supportive. Unless we end up in the hyper K situation, there's not a lot we do for these. They usually develop in the lower urinary tract where bacteria can enter and grow. More common in women. That's why women tend to have more UTIs than men. But with the addition of Foley catheters, lots of men are getting UTIs as well. They can reduce your kidney function because they're direct track to the kidneys. They can get abscesses. You can have bladder injuries where the bladder bursts, not necessarily from infection, but just in general. As you get older and your systems are weakening, and that's another really painful situation. Another one that can be difficult to diagnose. We are all really well versed in UTIs, I suspect. So I'm not going to touch on this too much, but I suspect anyone that walks into a room can tell me that it's a UTI before they even see the patient. So, kidney stones. The example on the right is a picture of a kidney stone. They're very jagged. They're very sharp. I will not lay claim that they are worse than childbirth, but I've had women say it. I think it's because after women give birth, they get that oxytocin release, and so they love their kid and they forget about the pain. I can't imagine it's worse than childbirth, but it's still very painful. Tend to have flank pain, especially down one side, and it can go all the way down into your lower region of your abdomen, and it'll still lean towards one side. If you've had one kidney stone, you tend to have more. Excess of salts and inefficient water intake will help develop these. It's uric acid that crystallizes, and they do have some therapies to get them out, so they can do it's like a pulse therapy where they can send some pulses in and try and break them up. They can put in some stents to try and dilate the urethra and help them pass, or they can kind of just let you go with it with some pain meds. And then I think there's one other, and I'm not super well versed in it, but I want to say it's like a laser therapy to help break it up, but I'm not positive. For us, these guys are going to be a lot of patient comfort. So if you're a medic, pain meds, and then otherwise a lot of supportive care to try and help them. Calcium stones are the most common, more frequent in men. There is a hereditary component. They will occur in patients with metabolic and hormonal disorders. Like I said already, it's very severe pain, and I'm sure we've all seen enough of these. These are pretty easy to diagnose as well. Your kidneys are the only organ that are going to give you that retroperitoneal pain, so kind of a slam dunk usually. Do you guys know what Gray Turner's sign is? So as we talk about bleeding into the abdomen, Gray Turner sign is bleeding along the sides into the peritoneal areas and retroperitoneal. You'll get bruising, but they won't have a traumatic injury necessarily to say why. They could. I mean, that may be what caused it. Or they could have had some other injury where they started bleeding, and they'll get this bruised buildup on the side of them. It's internal bleeding. Same thing with Crohn's, but Crohn's is in the center of your abdomen. It's usually around your umbilicus or lower, just because the fluid's naturally following gravity. Acute kidney injury. So we see a lot of chronic kidney patients. We also have the acute kidney patient. We already touched on this a bit, but they're going to lose their ability to filter blood. They're going to lose the ability to filter out toxins. Damage is often reversible if treated early, but can become permanent if left. Some of these patients might get a short-term dialysis or a one-time dialysis. Others, if they let it build up too long, will end up being on dialysis forever if it absolutely shells out their kidneys. Big thing for them is getting them into the ER, get some blood labs drawn, and then let them make that call. If they're backing up toxins and acid buildup, their mentation is going to change. So once again, the ammonias, the lactic acids. So do we know what lactic acid is? Okay. Lactic acid is strictly, it used to be a very strong indication of sepsis. We've learned more now that it is more an example of stress within the body. Your kidneys do not necessarily produce lactic acid, but they do help filter it. So if you have an acute kidney injury, you can't get rid of that lactic acid. It usually comes from tissue breakdown. So you can get this in crush injuries. You can get it in anybody who's got like bad ulcerations or any of those stress indicators. If left untreated, they can result in heart failure, hypertension, metabolic acidosis. So hypertension, one of the big risk factors of it is kidney failure, and it also works in the reverse direction. Chronic kidney disease is what we deal with more often. These are going to be your dialysis patients. They have inadequate kidney function. Some of them are waiting for a transplant. Many are not, just because of the age of the patient. We all know how much time they spend in dialysis, and it sounds terrible. There are some secondary disease processes from chronic kidney disease, much of which results from dialysis and just the kidney's lack of function. So we already talked about heart disease and hypertension, but you can end up with embolisms and hypovolemias just from the whole process of what they have to deal with getting kidney care. So chronic renal failure, nephrons of the kidneys become damaged and cease to function. They will develop scarring within them, just like your GI tract. Waste products back up, and then the systemic complications develop. So whether, again, I know I'm sounding like a broken record, but if your kidneys fail, the rest of your body gets taxed. If your liver fails, the rest of your body gets taxed, and they just back up to the rest of your system. Everything is important.
20% of all money spent Medicare on 65 and older kidney.
That's crazy.
Wow.
Matt said 20% of monies from Medicare is for kidney disease for 65 and older patients. Yeah, we're going to get into dialysis in just a second, and we'll touch on it a bit more. So here's your signs and symptoms. Much like a lot of the stuff in the rest of your book, it seems like it can cause every problem that we can see. So good luck remembering your signs and symptoms. Basically, if their kidneys shut down, so does the rest of the body. So you're going to see altered levels of consciousness first. Definitely could see seizures. Coma is going to be a little bit later. Nausea, vomiting for sure. They can get that flank pain. Hypotension is common. Tachycardia is common. Patients with end-stage renal disease will have lost most to all of their kidney function. They're certainly going to be on dialysis unless they are just riding out their remaining days. It's fatal without dialysis. So these are going to be the patients that go in 3 times a week for 3 hours a day, and if they skip a dose, they get really sick.
You ever see this? They talk about uremic frost, like building up on the face.
I haven't seen it, no, but Matt's talking about uremic frost for the online people. I've never seen it, or at least I've never noticed that I did. These guys are going to have confusion, shortness of breath, peripheral edema. Edema is common because they're not being able to filter properly. So all of their osmotic pressure is getting out of balance, and they're going to third space fluid. They'll have some bruising, some chest pain, potentially bone pain. They're just sick people in general. Seizures are common. One of the most common causes of seizures is hyponatremia. So as your electrolytes get out of balance and your kidneys are losing their ability to process properly, all of your electrolytes become messed up. So this is why we have our hyperkalemic patients. That's why calcium, magnesium get out of balance. Most people don't take in a very high amount of magnesium as it is. So we're struggling as a society with our electrolytes in general sometimes. Pathophysiology of the female reproductive organs. This is a bit of an exaggeration, but my instructors always told me any girl between 8 and 80 is considered pregnant until determined otherwise. Usually they will tell you there's no chance that they can be pregnant unless they've gone through menopause or they haven't hit puberty yet. I would always keep it in the back of your mind. Birth control is not always effective, and everybody's not always truthful. If they end up, keep ectopic pregnancies in your mind for them. They're very dangerous and certainly can kill them if not caught. Very, usually one-sided pain near one of their ovaries. Very, very severe. So pain may be related from the release of an egg during normal menstrual cycle. For those of you that want to have that deep conversation with your significant other or some other gal, some of them can tell you when they've released an egg and which side it came from. They're pretty in tune with their menstrual cycle. So if you want to get into the discussion, I bet they'd be willing to talk, and you can do what you do and listen. Remember pelvic inflammatory disease. It's another cause of acute abdomen problems. Intense pain in the lower abdomen, we already talked about this again. Fallopian tubes and surrounding tissues become inflamed. Are we pretty well versed in ectopic pregnancy before we move on? Yeah, okay. If it ruptures is when they have a big problem, but they'll have pain before then. All right, this is for the men, epididymitis and orchitis. These are more or less the comparison to pelvic inflammatory disease for the men's side. Often from some kind of sexual transmission. Epididymis is the area that semen is collected in prior to ejaculation. So this is where it's stored and built up. That can become inflamed and it causes a lot of pain. Orchitis is down closer to the testes and also causes a lot of pain. You usually have a fever and a foul odor. It is not 100% consistent with sexual transmission, but it is a common cause of it. And honestly, if this is what they have, it's neither here nor there for us to say or even really care about. They either have it or they don't. Have a lot of referred pain into their groin, and usually for everybody in here, you've probably been kicked, and this is just a constant pain like that. Priapism is a painful, tender, persistent erection. I have never seen one, but I have been told that it is beyond obvious, and like you look at it and you know that they're in pain, but you're almost proud of them. If you want to think of it that way, like they're there. Diseases such as leukemia and tumor can cause this. Blunt perennial trauma, but a common one is spinal cord injury. So when a lot of our trauma patients try and keep an eye out for it, it sounds like you won't be able to miss it, but I've never seen it. So it says cocaine can cause it too, so I guess if you like to party. Maintain the patient's privacy. Do not make assumptions about the cause. Obviously, we can ask about Viagra and those things as well. So if they're over 4 hours, it becomes very painful, and they need to get in and have some of that blood drained. Side note, who knows what Viagra was initially developed for? Cardiac. It was a cardiac med that they found had better uses. Same reason that you can't give nitro when you've been giving Viagra is because of the blood pressure issue. So. Yeah, probably. Same idea. Very similar effect to nitroglycerin. And Matt brings up a good point that women take it too. So we don't like to ask women if they take Viagra, but some will if you ask them. So before you give nitro, say, I know this is going to sound crazy, but you don't take Viagra, do you? And they'll look at you like you're crazy 99% of the time. But if you catch that one and they already had low blood pressure, it can save you. Benign prostate hypertrophy, not typically going to be a big issue for us other than the urinary retention. They can get that bladder fill up. This happens to a large portion of men as they get older. There are some meds to treat it, and for us it's going to be a lot of just comfort and care treatment. All right, testicular masses. So we're talking about cancers and things. Definitely painful, can radiate up. Is anyone in here doing hands-on evaluation of testicles? Okay. Most cases, there are some cases where you should probably look, but more often than not, it's okay to just believe them, just to not invade their privacy. Now, if it's that bad or you think that you need to visualize it to get a better picture of what's going on, then by all means do your job. But some of these are just, if it's just some general low quality pain, just take them to the hospital and let them deal with it. If they're in a lot of severe pain, you might take a look because it might change your decision how quickly you get them there. Has anybody heard of a penile fracture?
Dennis Rodman has a video about that.
So that's one of those ones that we may not want to look at per se, but if you ask any guy in this room, that is an emergency scenario and requires lights and sirens. Testicular torsion, very, very, very painful. Known some people that have had it. It's nothing that you did to cause it. It just one day they kind of wrap around each other, and it's extremely painful. Once again, it's kind of like being kicked in the nuts as hard as you can and then just doesn't go away until they go in and fix it. It can reduce blood flow, so if not treated, I don't know why you would wait to not have it treated, but if not treated, it can cause you long-term damage. We kind of already talked about this. Just bleeding can lead to profound shock. Hernias can protrude through the tissue, and you'll see it in the body cavity. You can usually palpate them. You'll see this if you start looking at a lot of your geriatric population, especially like an older person, they got their shirt halfway up or off. When they go to sit up, you can usually see a hernia in their system. Like, not usually, but often. And if you ask them, a lot of them know they have it, and they're just not treating it. It's just being left alone. Some of these can be a big problem. These, in theory, can be pushed back. I don't really see a good reason to touch it, unless you're trying to palpate around for pain. They can be a congenital defect. They can be a surgical wound. They can be from something as simple as playing sports. So most people have known somebody with a hernia. They're more often than not a big deal. If they develop a strangulation, it is a big deal. So these are the common areas for strangulation. Basically, you've cut off that area of the tissue. It's no longer getting blood supply. Food's not getting through it. You're literally strangling it, and that actually is an issue. So that's going to be a definite transport. Depending on their condition as you're looking at them, probably not lights and sirens, but definitely need to get in. Not something that should wait. So here's some more signs to go along with it. Tenderness, the red or blue skin discoloration over the hernia. I've never seen a strangulation that I've caught. And the mass is no longer reducible because it's been so cut off. So ensure that the scene is safe. On your size ups, this is all very basic stuff. The mechanism of injury may be the result of violence or other trauma. So just because it's abdominal pain, don't write off the other potentials for that. If several patients complain of GI symptoms, we need to start considering toxins in the environment. We kind of went through most of this already too. Check for your referred pain, hematemesis, hematochezia. GI problems rarely affect breathing difficulty. Ensure the airway is clear, it says, but they tend to not be closely associated until you start developing shock symptoms or sepsis. And that's not necessarily that the abdomen's causing the problem as much as your system shutting down. We went through all this. Check pulses in both arms. We touched on that earlier, especially with really bad shock situations and or aortic dissection. So you're getting better pressures to one side of your body than the other. Orthostatic vital signs. I do these all the time. I'm not sure about everyone else. Usually an indication of dehydration, but can be causes of other things. If you can put them on a 4-lead while you do it, it's even better, because you can see if their heart's being put under more stress. But very basic blood pressure and a pulse. Stand them up or change their position. After a couple minutes, 1 to 2, check their pressure and their pulse again. If you have a change of more than 10 in either direction, it's an orthostatic change, either orthostatic hypotension or orthostatic hypertension. Like I said, more often than not, it's dehydration, but definitely can have some other causes. And basically, it's their body's inability to compensate properly. So make your transport decision. We're pretty lucky around here with how many medics we have. So if you guys want, there's no harm in always requesting that upgrade, and anymore there's medics on just about every bus. So there are going to be those weird situations here or there where it's just ILS, but it's pretty rare anymore. If you're in the back of the bus and you took a patient, you start getting into it and you feel like something's changed or become more serious, we have that little window you can talk through. There should be no problem with doing a hot lap if the patient's condition warrants it, or at a minimum upgrading for the last mile or two. So keep those things in mind. Just because it seemed basic at the beginning doesn't mean you don't find something else on the way. These get into different types of pain. So visceral discomfort we talked about being hollow organs. Somatic pain is the peripheral nerve tracts. Referred pain is a nerve tract but specific to disease process. And then rebound pain is the peritoneum, specifically with appendicitis. We all know sample. When you get into the end of sample asking about their bowel habits, their urination, that can tell you a lot about their current condition. And it's kind of an overlooked question sometimes. Belching, flatulence, anything that they feel is abnormal could lead you to that clue. If I told you I've lost 30 pounds recently in the past month, what's your first suspicion? Could be, not likely for 30 pounds, but could be. Cancer. Cancer is a big weight loss one. Changes your eating habits, it changes your ability to keep stuff down, it changes the way your body uses stuff, so you can lose a lot of weight with cancer. Some of these bowel ones, like Crohn's, colitis. So for those of you who don't know, I have Crohn's. I lost 30 pounds in a month, and I don't have 30 pounds to lose. But it just changes your ability to absorb anything or eat anything. And so you go through that process of being sick and then really sick, and then they lose a lot of weight. So if you have a rapid weight loss, somebody's sick. Along with that, if they've had a rapid weight loss, get into their history a little more of why. Sometimes it's a weird diet thing. So if somebody decided that all they're going to do is drink water for the past month, their electrolytes are going to be all out of whack. I've seen one where a kid lost like 100 pounds in a month. All he was doing was drinking water every time he got hungry, and his ECG was a sine wave, and he was super, super sick. But you got to prod these patients a little bit if it's not quite making sense. If chest pain is reported, walk down that route. Like we talked about epigastric pain, consider chest stuff. Ask about their last oral intake, check for trauma. Patients with peritonitis usually have abdominal pain. I feel like we already covered all this. This is your secondary assessment. So I'm happy to do this on the primary assessment, and I recommend you guys consider it for your test. It says it's a secondary thing to get really deep into this. It's, I think, referring it to like rapid assessment, detailed assessment. But lay hands on them, really get into their tissue. If it's super tender, don't cause them a lot of pain, but you need to try and figure out if you can localize it or not. And then it looks like he may even be checking out that McBurney's point we talked about earlier. Check their respiratory rate, pulse rate, blood pressure, bring in that full picture of vitals. Remember your stages of shock. Remember that these patients are going to hold on and then crash. So if you were just in for instance, I had a spleen lac one day, was in a bicycle accident, took a handlebar to the gut. Vitals were relatively compensated, it appeared, but he was also pretty worked up from the event. He's in pain, so it almost got written off. Took a closer look at him, decided to run him in, and he ended up having a splenic lac and became very hypotensive when he hit the ER doors. So had that been a patient that you're like, yeah, you're a little worked up, let's just slow roll this, or better yet, let's let you go POV, there's a chance that they get really sick and don't make it. Reassess. A lot of your intestinal tract probably isn't going to change massively over our transport times, but the rest of the organ systems can. So keep an eye out for those. And then it says consider your paramedic backup. Acute abdomen can be a serious medical or surgical. We've already talked about that. This is all basic. Maintain your ABCs. Before transport, anticipate vomiting. Emesis bags are your friend. Anticipate. So if you are in the area of solid organs, start your IV early. And then, because if they're pressure dumps, you're not going to get it. So I know we're working hard to do skills that we're going, as far as billing goes, that we're going to be using. But if you can justify that you think they may have a change in their condition, it's still appropriate to start your IV, even if you're not giving them fluids currently or administering meds. So you can document it as a potential, and I'm not sure how the system feels about this, but this is how I've been doing it. It's a potential change in patient condition that I want this IV because their condition can change and then I won't have that opportunity. Make them as comfortable as possible, monitor your vitals, consider calling for paramedic backup again. We touched on all this already. We touched on the childbearing age women. They are considered pregnant until proven otherwise, and always keep in mind ectopic pregnancy. We talked about pneumonia. Went through all this. Okay. There are two types of dialysis. Does anybody want to tell me what they are? Or has anyone seen the second type? Okay, so there's hemodialysis. This is what we constantly run on. This is all the dialysis shops around town. They're hooked up to the dialysis machine. They sit there for 3 hours. Peritoneal dialysis can be done in a facility, but it can also be done at home. They inject some fluid into the peritoneal area, and it washes around on the kidneys, and it causes diffusion, and then it gets pulled out. It's kind of funky. We don't see it very often anymore because dialysis facilities are so prominent, but some patients want the ability to do this on their time and their travel, and maybe they're not quite as severe as the other dialysis patients, so they'll opt for this route. I have only seen one up here since I moved here, and I saw one in Oregon. They're not very common anymore. It used to be more commonplace, but not anymore. What are the dialysis patients going to have that we need to watch out for in their arms as far as IV access? Fistula. If you touch a fistula, the nephrologist is going to be pissed. Don't do it. They have other veins. Even the ER is not allowed to touch them unless it's an absolute emergency, and even then they're a little leery. We have other options. Try and find them. If they're in dialysis, they can get an air embolism. We've already talked about electrolyte imbalances, myocardial ischemia. It is 100% common for renal dialysis patients to develop hypotension during and or after the procedure. One of the most common things we take these patients in for is hypotension. So you need to treat them still, you need to care for them, but don't absolutely freak out that you think something else is going on because it's totally common. Really important to ask how much fluid was pulled off and how much was put back in. They'll usually be able to tell you those numbers because they do this all the time. If not, the clinician at the facility certainly can. They get an infection at the site. They'll have an altered mentation if they're sick. These guys tend to get sick pretty quick too. If they skip dialysis, they can get sick, especially if it was so usually it's 1 on, 1 off, 1 on, 1 off, 1 on, 2 off. So if they went through the weekend and then they skipped Monday or they skipped Friday, then it's even longer than the midweek skip. So they can get sick pretty quick, and they're going to feel pretty crummy. So ask them when their last dialysis was and how the procedure went, if they've skipped any others recently. Usually they're pretty good about it, but occasionally they get sick, and if they get sick, they don't go. So if they are actively being dialyzed, the facilities are actually pretty good about maintaining patient care until they're at an appropriate level where dialysis can be stopped, unless it becomes really emergent. If it does, when we really need to think about how much fluid has been pulled off of the system, and then how much they need put back in. So very basic, this becomes a 911 call. Start with your ABCs, be alert for a leaking shunt, and then treat them accordingly to whatever they present as. Probably going to be an ALS call pretty quick, because we're going to want them on 4 leads and things. But at the end of the day, this is not much different than somebody who's bleeding out somewhere. The only difference is their kidneys don't function well. So we do want to put fluid back in. Also keep in mind we don't want to overload them. So they have a hard time removing fluid from their system. We only want to give them enough fluid to maintain them at a safe level. If we start going over that, then it's going to stress their system even more and they've got to get it pulled off. So these patients need a lot of balance. You can't just hammer them with fluids. Side note too, if a lot of fluids that you put in, especially if you're just pounding them with fluids, not all of it's going to stay in the intravascular area. So if they don't, the hospital is really good about measuring how much fluid goes in and how much comes out. And there's formulas and things that need to be within certain ranges. We are not. We just think we can give you all the fluid in the world and then call it a day. And the reality is that we need to account for that fluid because a lot of it's going to third space. So keep track. If you're coming from far out, you've given 1, 2, 3 bags maybe. That's a lot. And the ER needs to know exactly how much you gave. Disequilibrium syndrome is not uncommon in these guys. So they will get, once again, that water shift into the cerebrospinal fluid. It will increase their intracranial pressure. After a few hours, it will usually recalibrate down, but that can cause them problems associated with intracranial pressure in the meantime. And just treat accordingly. And then obviously air embolisms are always a concern, whether you're starting an IV or you're going through dialysis. That's just part of it. We're done. Questions? Yep. Online questions, you good? It's kind of a down and dirty section. There's only so much we can do for it. Awesome.
Thanks, Cody.
You're welcome. If you guys need help with anything as you go, I'm a resource you can reach out to as well as everyone else you work with. So, yeah.
Actually, my key takeaway.
All right. Have a good day online.
Oh, I've had not personally.